Luis, are you still there?
I'm here, Dr. Mishkel. Do you hear me?
Yeah, I can. So, John, thanks so much for inviting us. And maybe by way of introduction, I'll tell you a little bit about myself, and then I'll introduce my colleague, Dr. Luis Paz-Rios. And Luis, did you have a slide or two?
I do, Dr. Mishkel. I have actually a couple of slides with the questions in particular, so we can emphasize on them as we go through them.
Great. So I'm the Division Chief of Cardiology at North Shore. I've been here almost 2 years now. And Luis is one of our cardiology fellows, second-year fellow. He has one more year of training to do with us. And we're very proud of all of our fellows, and in particular, Luis is going to be leaving us after the end of the next academic year to go to Harvard to do an extra year of training. So we're very proud of how well he's represented us. In answer to your question, this has been our most remarkable year for all sorts of reasons. I think we're going to restrict our comments to the pandemic, which really we haven't seen the likes of which ever, probably from this audience, since the great flu of 2018. But lots of lessons to be learned about that pandemic and the course it ran, and this particular pandemic. We are seeing some very unique aspects related to the pandemic. We initially thought that this pandemic really just affected people's lungs, and you would get a very severe type of pneumonia or flu. And then we learned, lo and behold, it affected people's hearts. And then we learned that it affected the clotting system. And then we learned that it affected, we knew that it didn't affect kids. And then we learned that there's this after syndrome in some unfortunate but small number of children, which we've never really seen before. So there's lots to be learned about this particular pandemic. And Luis, are you able to share a slide or two about in terms of how it affects your heart?
Let me give it a try, Dr. Mishkel. I am putting here. Are you able to see this display?
Yes, we can.
Okay. Do you see that PowerPoint slide there?
Yep.
Okay, great. So, well, first of all, thank you for the introduction, Dr. Mishkel. I mean, really get high appreciation for this place where I train, and it's not without saying that most of my future endeavors are also with a lot of the push that I got from our department and with the amazing training that we have received during my 2 years already. I want to say thank you everybody for allowing me to be here and to allow me to perhaps provide with Dr. Mishkel some sort of guidance and some sort of filtered and perhaps more digested information in terms of what we know and what we what there is to know about the pandemic, because one of the big things that I probably will have to say repeatedly during the time is that we are learning with giant pace every day about this disease, and it's just doesn't stop surprising us so far with the things that we have discovered and the things that we understand about it every time that we see things. So I'm going to get to the questions. I just want to give a brief one slide of our current situation, and I copied and pasted this from, I'm not sure if most of you may be aware, the Johns Hopkins Institute. I mean, the Johns Hopkins University has this monitoring, and it's if you put in a Google search, for example, Johns Hopkins COVID-19 monitor, you will definitely find a direct link to actually see the live updated version of this. This is from this afternoon, and again, we are almost reaching. I mean, we have passed the 7 millionth case in the world, and we have passed almost reaching the 2nd millionth in the United States, with more than 110,000 people that actually, unfortunately, have passed away due to this disease. So this is a question that I received today, and I'm just going to go through the questions, but in a way, with the collaboration of Dr. Mishkel, we're going to answer what is the general concept of what we have, the information that we're handling. And I mean, just to cut to the chase, the first question is just why are patients at higher heart patients at higher risk when it comes to COVID-19 disease. And I will say, in terms of answering these questions, well, heart disease patients, unfortunately, are at higher risk, not only for COVID-19 disease, but for a lot of other conditions, because heart disease is kind of like an inflammatory condition. There are risks implicated in acquiring diseases, especially infectious diseases, to any patient that has an underlying heart condition. So this is not an exception for COVID. And in terms of numbers, for those of you that like the numbers, there is about a 7% injury to the heart in patients with COVID. And in those that actually acquired the severe disease, the COVID with critical illness, that we call it the critical disease, up to 22% of those patients actually will have some sort of myocardial injury or myocardial disease or compromise. The why, there are hypotheses. It's not that we have nailed down the reason specifically, but probably in the big scheme of things, and some concept that is in the mainstream is there are particular receptors and very dear to the heart and to the cardiovascular system called the ACE2 receptors. ACE2 receptors that are also present in the lining of the lungs are the places where this virus adheres and enters and also reproduces itself inside of the blood cells, inside of the cells of the body. So our cardiovascular system is rich of these receptors particularly, hence perhaps more exposed to the presence of the virus and to the deleterious effects of the virus. Now, these receptors are not only there, they are present in many, many organs, but they're particularly rich in the cardiovascular organ. I'm not sure if you would like to add anything to that question, Dr. Michel.
Well, I think you've explained the biology that very nicely, that there are actually receptors that the virus attacks not only in the lungs, but in the heart. But additionally, I think that there are demographic factors about a lot of patients with heart disease, in that they're older. And they also tend to be patients who have diabetes, and they tend to also be patients who have high blood pressure. And all of these risk factors in combination or singularly increase the risk of developing any illnesses, as Luis has pointed out. And the older you are, or maybe the sicker you are, the less likely you are to have a milder case, and the more likely you are to present with an illness. So it becomes much more obvious that a heart patient has the disease than, say, a young, healthy patient. So there is something called what we call ascertainment bias, which means you are more likely to see it because it is more likely to be visible. But there's probably a lot of patients out there who have disease that they just passed off as a cold or a flu.
Very well. So I agree with the statement 100%. So for some reason in my screen, half of the screen is invisible, Dr. Mishkel, and I may actually be missing some of the words here. But going through the second question presented to us, what should heart patients be doing differently during this pandemic in terms of routine medical care, checkups, regular visits, what can be postponed and what cannot be postponed, determine when they might need an emergency? These are multiple questions, and I probably will go one by one. In terms of routine medical care, it's naturally, and you probably may have seen that at North Shore, many things have shifted towards telemedicine, for example, which is a great alternative for a just routine medical care or a routine checkup, where the presence of a physical exam, although it's always important and it gives us a clue of what's happening, not always will be, I will say, something that we cannot, we don't have to do it all the time. It's something that sometimes can be avoided, and sometimes by the mere action of speaking to the patients, gauging from symptomatology or gauging from complaints, if there are any complaints, the overall health or the overall, let's say, status of any diseases that we're following up. I think the virtual consults are an excellent way. We have adapted and we have shifted towards providing the patients still a follow-up, a regular follow-up. In terms of testings, and that's what I mean with checkups and regular visits. In terms of testings, in the same manner, I will say some tests might not be necessarily something we have to routinely follow up. Some of them, in the case of the last question and the last portion of that question, what if they are on warfarin? So there are testings that are definitely necessary. And in the case of warfarin, yes, checking the INR for those of you who are familiar with anticoagulation and the INR checks, that's something that unfortunately has to be measured. Great initiative that was placed by the cardiovascular department. Actually, we have a drive-through INR checkup clinic, and that's present at Skokie, where you basically, similar to when you go to a, let's say, a Chick-fil-A or a McDonald's, you just go with your car. Somebody with all the personal protective equipment will approach you. You stick the finger out of the door. They will like just prick you in there, and they will check your blood, and they will call you with the result of your INR. So that's an initiative that was held, and that was actually, I think, very fruitful in terms of the INR checking, which is one of the laboratories that we kind of rely on in terms of modifying medications. But when we're talking about other, I mean, this is maybe something that we can apply to other kinds of laboratory testings, but ideally, if there is something that is really something that you need to come to the hospital and get it monitored in the hospital, I probably can reassure you that in North Shore, there's just enough protective strategies. There's a lot of screenings, and there's a lot of ways to avoid putting the patients at unnecessary risks. And whenever we say whether or not something is to be done, I think that has to be in communication with your primary cardiologist or with your primary physicians as well. That's something that always has to be raised. And, you know, it's kind of like a two-way communication.
Can I jump in on that? I mean, are there things that aren't being done now at the hospital? I know that was the case in the worst of it, but what's the status of what the hospital is doing and not doing right now?
So I think what Luis has been describing is what I call looking in the rearview mirror. It's what has been, and the precautions that we did and have done up to now. And telemedicine was a very important maneuver that virtually the entire medical profession adopted. And so for 3 months, we literally shut everything down and tried to postpone as much as we could and do literally every visit short of an emergency visit with telemedicine, with all the challenges we all had to face that get more difficult as you get older, like how to figure out Zoom, do this on your phone, et cetera, et cetera, et cetera. So where are we now with this pandemic, and what about healthcare delivery at North Shore and elsewhere? Well, what we have done with this pandemic is, as many of you have heard, we have flattened the curve, meaning that the virus is still with us. It's still circulating in the community. We do not have a vaccine, but the rapid spread from person to person to person has been mitigated through many of the activities that we've all undertaken. It has not gone away, but we are seeing daily now decreased presentations to the hospital. So by way of example, just 3 weeks ago, we had probably close to 200 patients in the hospital in the North Shore system. As of today, we're down to 40. And each and every day it's going down. So we're in the containment phase, and where we are as a system is, number one, we have enough personal protective equipment for every healthcare provider. It's very, very important. We didn't have that in the beginning. Number two is we have an extraordinary access to testing, meaning regardless of who you are, where you are, potentially whether you have symptoms or no symptoms, you can get tested now to see whether you have COVID. On top of which, if you're a North Shore patient, we can also do a reliable antibody test that you can order for yourself on North Shore Connect to determine whether you have been infected with COVID at some point in the past and might be immune. That's very, very important. So the activities that now we're undertaking, and we've done this for the last 3 weeks, is that offices are now open. It's going to be a different experience. because everybody that you'll come into contact with will be wearing a mask. That should make you feel better. The waiting rooms have been reconfigured to have chairs that are 6 feet apart. We're doing a lot of things virtually. And again, I like to think that we're ahead of the curve, but in truth, this is happening really across the city and across the nation. But we're doing a lot of things virtually, like you'll check in advance. You'll stand back from the person at the counter. We'd like you not to come with a lot of family members. And when you leave, we're not going to have you leave with lots of paper that people have been touching. There's not going to be lots of exchanging of materials. There'll be at most a fist bump, not a handshake. And that you'll see a lot of hand washing, which is probably one of the most important things you can do. So I feel personally, during this pandemic, although I had the opportunity to work at home, I came to work every single day, and I walk and work in the hospital every day. And I honestly think at this point in time, there's probably not a safer place in terms of your health than your physician's office or the hospital. You might not be aware that at North Shore we had the foresight and maybe a little bit of luck that we were actually able to convert Glenbrook into a COVID area. That's not to say that Glenbrook shouldn't be used for other things. In fact, we've reconfigured Glenbrook with different types of airflow that allow you to contain the virus. But we don't have COVID patients scattered throughout the system. And we've reconfigured the emergency room at all sites such that you're triaged separately, and anybody who has respiratory symptoms is put in a different area. And everybody who comes to an emergency room now gets COVID tested with the 45-minute test. Not the 5-minute test. The 45-minute test is a little bit more accurate, so that we identify everybody in the emergency room before they're even admitted to the hospital or discharged home. Do they have COVID? And so that's another way of safely excluding non-COVID patients from COVID patients. So I would say at this point in time, coming to your physician's office is very, very safe. Going for tests that we may have put off is very, very safe. And then over the last 3 weeks, we have begun to do the elective procedures. We never stopped doing emergency procedures. We have begun to do the elective procedures that were otherwise put off. And again, that will be a new normal. You have to go get COVID tested before you have one of these elective procedures.
Are there a backlog of patients waiting for various heart procedures because of all that?
I would say at this point, and I looked at our statistics today, that we have gone through about 85% of the backlog.
Okay.
There is still a significant number of patients who want to put off regular or even more than routine testing. So there is a fear still in the community about coming out of quarantine. I mean, we really, it is quite remarkable at how seriously many of these people have taken quarantine, and now it's tough to break that habit. And that will take time and maybe even word of mouth that, people are confident that nobody got sick by coming to one of our facilities. The same holds true about blood work. You can go and get your blood tested at our various facilities, and the same kind of precautions that occur in our offices will also occur in the labs environment.
Great. So one of the questions on there about emergency room, I mean, there've been stories about people being afraid to go to emergency rooms. So the procedures have all been changed there, and there's more safeguards in place now?
I'd like Luis to kind of comment about that phenomenon, because it's really been quite remarkable.
Okay.
Can you repeat the question one more time?
What happened with emergency room care when we look in the rearview mirror, and what about moving forward if you have an emergency?
Yeah, so I will echo what Dr. Mishkel has mentioned. So emergency room has been one of the most probably evolving fields because they are the front line and they are, for all terms of purposes, the most exposed physicians or at least healthcare providers. But nor sure what I have seen, at least when I'm in service. I was in service in Highland Park. I didn't experience the Glenbrook. I will say the Glenbrook experience thus far. But the emergency rooms per se, they have been adapted in such a way that it's you get a containment of the patients that are potentially patients with the virus, and then all the personal protective equipment and the way to interact with these individuals that are ill in the emergency rooms is enough to tell you, okay, there is really no risk of this being, I'll say, spread in the emergency room departments. In terms of emergency procedures, and going back to the question that you asked before, there has been a dramatic, I will say, decrement of cases in terms of patients that have been trying to put off even emergent situations, the typical either chest pain syndrome or symptoms that patients used to, because of our awareness nowadays, will come to the emergency room making sure everything is okay. And there has been a little trend up on more, let's say, late presentations of these cases. So from our perspective, what we have seen is that our patients have been trying to put off a little bit their symptoms, trying to hold it at home and say like, okay, it's going to go away, it's going to get better. But at the end of the day, these things sometimes complicate our patients to the point that it becomes more at risk for them to wait so much because things can get a little complicated and pun intended, because when you're talking about chest pain syndromes and we're talking about potentially heart failure decompensations, all these diseases that we see in our everyday basis, that there was a significant decrement of those cases. Patients have suffered. I think they have suffered through bad symptoms of the
I'm
disease.
listening.
So I think this is slowly reversing. I think now, well, there might be two ways to think about this. It's either the patients are feeling bad enough that they are actually coming to the hospital because they don't feel good enough to stay at home any longer. Or the second thing is, I think people have realized that, at least in our institution and in our health system, there are ways that we have been able to safely care for them, and they have been hospitals. Particularly, for example, I spent a whole month in Highland Park, which it feels like you are in a bubble. Feels like because of the redistribution of our patients, because of the upfront testing and being able to identify those patients that are positive, localize them in Glenbrook, and in the same manner, all of those who are not positive, put them in the hospitals that are, let's say, or clean hospitals, let's say like that. It feels like the care that is being provided is so efficient that things feel like you are back to normal. That's the way I felt for the last month or so at Highland Park Hospital.
So, John, one of the stories that have come out about this, which is concerning, it's most evident in New York City because that's where most of the cases were, is that we see mortality rates that are about 7 to 10% higher than can be accounted for by just deaths attributable to COVID. Meaning that we believe that in addition to the deaths that were related to the COVID pandemic, there is additional mortality that we haven't identified, but there's clearly additional mortality likely related to excess deaths from heart attacks and strokes. And anecdotally, when the emergency services, paramedics, EMS reported in New York City that they saw many more cardiac arrests and deaths in the home. And perhaps for good reason, we heard this over and over again. I'd rather die at home than go to the hospital and die with COVID. And I think in part, that's twofold. One is the disease is really scary, maybe threefold. The disease is really scary in and of itself. Number two, early on, we did not have a lot of effective strategies or treatment. And number three, and I think this is really crystallized as you get older, the fear of dying alone. The precautions that we took to prevent transmissibility, not having family members see patients in the hospital, is a very, very scary thing for patients, and frankly, from people I've talked to who are healthcare providers, very disconcerting to the staff who often had to care for these terminally ill patients without family. In the same way, having family in a nursing home and not being able to visit them is very difficult. So I think that those are some of the medical and psychosocial issues that have come up. What to do about today, I would say the most important things that you can do in terms of getting back to normal are, number one, social distancing. So although people are beginning to gather in crowds or socialize, I think you don't want to expose yourself to high density events. Now, whether eating at a restaurant is a high density event, that's a personal choice. Hopefully if you're going to do that, you're going to go to a restaurant where you're going to be spread out. And frankly, being outdoors versus indoors, not your own home, is safer. So eating outside, for instance, is safer than eating inside at a restaurant because you have the environment dispersing the viral load. So number one is social distancing. Second most important thing is washing your hands over and over and over again and not touching your face. So these become learned behaviors. I live in an apartment building. I don't ever touch the elevator button with my fingers anymore. It's always with an elbow or my keys. And then I try, I really work hard to not touch my face. And every time, literally every 30 minutes, I'm looking for alcohol to clean my hands. And then the third thing that you can do is wearing a mask. Now, wearing a mask is like a social contract. I do it to protect you, John, and you do it to protect me. Because the truth is, the masks that you see in public, either the surgical masks or the masks that people make and buy on Etsy, they're not really filtering enough viruses that, unless somebody directly sneezed on you, you're better off with a mask. What you're doing is you're preventing transmission. It's preventing me from giving it to you and you're not giving it to me. It's really only the N95 masks that you see medical providers who are directly caring for patients with COVID that are effective at reducing inhalation of the virus. So masks are the third thing, by far and away, social distancing and washing your hands. And I would say getting outside is important and frankly, at some point healthier.
Do you think that will help? We're almost out of time here. I just got a notice from Zoom, 5 more minutes. But do you think that goes to the psychological state of heart patients? I mean, it's difficult enough being a heart patient, but being sort of trapped inside makes it harder. Are you advising people to get out, walk more?
Well, this has been an incredibly thank you, Luis. This has been incredibly stressful. I mean, just myself, the anxiety that you feel about your own health and your family's health and your community's health. And we have seen alcohol consumption. It's both a hobby, it's become a hobby and a relief, right? Mm-hmm. And they used to talk about the freshman 15. Now we talk about the COVID-19.
That's my bottle of wine.
So I think that the psychological toll that this pandemic has put on us all, and then particularly when you have heart patients who are very, concerned about their health, and then you have this, it sounds like it's instant death if you go outside. And so somehow we have to get back to a new normal where we can be more healthy physically and clearly more healthy mentally. And there are resources at the American College of Cardiology. In fact, the CDC website has psychological resources and advice that people can get to. I think the most important thing, and I think maybe this is one of the good things that's happened, is that I think there's a lot more communication between families now. And I hope that people who experience anxiety or depression reach out to their family members and talk through some of these things. But as I say, I'm encouraging people to try and create a new normal that's smart and will actually protect us against future diseases. My bet is that the flu season will be much better this year than it's ever been. Why? Everybody's going to get a flu vaccine for sure. And number two, all the things that we are doing to protect ourselves from COVID will protect ourselves from the flu.
One quick question here from somebody on the call. What about having workmen coming into your house? What are your thoughts about that?
Well, that's a calculated risk, right? You
absolutely.
Assuming that you can maintain 6 feet of distance and that they wear a mask and you wear a mask, and assuming it's important that they come into your house, I would say at some point you have to do it. And you have to just take the precautions that I've outlined: social distancing, wearing a mask, and washing your hands, and making sure they do the same thing.
Okay, and Luis, the slide you put up is what the doctor was talking about, the American College of Cardiology.
Yes, exactly. So this is a patient-oriented web page from the American College of Cardiology called CardioSmart. And CardioSmart is free now in the situation of COVID, and there's plenty of resources there for patients, especially for heart patients related to COVID, what things to avoid, how to relate in the environment. I think there is a small area in that web page where there's stress-related things to do or how to deal with the psychological toll of the COVID. But as Dr. Mishkel mentioned, not only the CardioSmart, there's a lot of other resources. The CDC has actually a large amount of information. And one of them that I liked a lot for our patients, and it is free for patients, is called Up to Date, just like the word says. It's a wealth of information regarding COVID, patient-oriented, in very lay terms, I will say it, and with very nice information for you to actually have available.
All right, great. Well, I'm getting the cutoff note here from Zoom. So thank you both very much, our two doctors. Thank you so much. And thank you everyone for joining. Next month, we're going to try and get our chefs to do some Zoom cooking for us, to do some heart-healthy meals for July, which I think was our original topic for July. So we're going to try and put that on Zoom. So thank you, everybody. It's great seeing everybody.
Thank you so much.
Luis, appreciate it.
Bye-bye.
Thank you very much.
Good night.
Good night.
Good night.
We're going to do the Zoom wave now.
Night.
So
Good night.
that's become the new universal greeting, the Zoom wave. So, thanks, everybody.
Thank you.
Good night.
Good night.